Welcome everyone, thank you for being here today. I'm Shane Miller, I'm a pediatric sports medicine physician here at Scottish Rite and UT Southwestern, and I'm excited to be able to talk to you guys today about sport-related concussion management. So we are going to spend the next couple of hours going over hopefully some good highlights of things for you guys. I don't have any disclosures to share relevant to this particular topic. Today's objectives, we're going to start by reviewing recent literature and advances regarding sport-related concussion. That'll be included as we go through the talk. We're going to discuss the latest guidelines regarding return to sport. We're going to review components of House Bill 2038, also known as Natasha's Law, and we will, in the end, satisfy the training requirements for UIL purposes. So this is the syllabus that comes from the law there. So we have a lot to cover in a relatively short period of time, and so hopefully we'll get through a lot of this, but we're going to hit on a lot of highlights today. So we'll get started with part one. So these are some questions we have today. We'll go through a few of these together. So question number one, how many states have a concussion law? Is it A, 28, a show of hands? If you're at home, you can think through this on your own. B, 37. C, 44. D, 50. So those of you online, come up with your answer, and then we'll move forward here. So the first law was signed in 2009, also known as the Zachary-Lystedt Law. This is in the state of Washington. I was fortunate enough to be there in 2009 when this was signed into effect, and that on the right there is a picture of Zachary and his parents. Zachary was a young man who unfortunately suffered a catastrophic brain injury during a football game, and he had an initial injury and then was subsequently returned to play and suffered a second injury, which was, again, catastrophic. He has survived the injury, but has been neurologically devastated due to that. So his parents and Zachary, and along with others such as Dr. Stan Herring and others in that state, really helped push. A lot of this was education. They wanted to educate and hopefully help prevent other similar injuries from occurring in the future. So 2009, the first law was passed in the state of Washington. 2 years later, we had what's known as Natasha's Law in Texas in 2011. So I want you to know a little bit about Natasha Helmick here. So we're going to move to a video and let Tasha tell you a little bit about herself. This comes from the Texas Sports Concussion Partnership website.
My name's Natasha Helmick, and I'm 22 years old. I've been playing soccer since I was 4 years old, and my soccer career ended my freshman year of college due to a concussion. I got my first concussion, I was around 12 years old. I didn't know it was a concussion at the time. I was in a soccer game and I went up for a header. A girl next to me went up for the same header and her head hit me in my temple. I went down, they stopped the play, I got up, they asked if I was okay. I said I was fine even though I wasn't. My head just felt like it was wanting to explode. Went off to the sidelines, sat there, looked my coach in the eye, sat there and looked at me and was like, "Tasha, are you okay?" I said, I'm fine, put me back in. I wasn't playing normal because for the next 60 minutes, the remaining of the game, I couldn't see out of my left eye, so I was missing balls coming in from this direction, and my parents were walking over to me before they could even make it to me. I just started throwing up, vomiting, signs of a concussion, and that was my first concussion. Did not know it was going to be a trail leading on to many more. The next one probably would be going up for a header again, and girl hitting me in the back of my head with her head. Just remember hearing the loudest ringing noise. Everything just was moving in slow motion. I continued just to play through it, and the ground was just going like this, back and forth, and I couldn't tell what was the ground and what wasn't the ground. 2 days later, I went to school, and that was really hard. Couldn't even really make it through a full day of school. I would just start feeling dizzy, like I'm gonna pass out. I would start seeing 2 teachers. I would start seeing 3 pencils. It was just really frightening, I guess. I just really wish I wouldn't have tried to play through and be the tough person. And I just didn't want to let my team down. I didn't want to let my coaches down. But in the end, I was letting myself down. So, because in the end, you know, they don't have to live with like what I feel today. You know, that was my choice to stay in the game, to try to tough it out. They don't deal with the day-to-day things I have to go through, whether it be I'm really dizzy one day or I have really bad headaches. I don't even want to get out of bed, you know. They don't feel that. And all those games I went back in or toughened it out and kept playing, I don't even remember any of them anyways. So I kind of look back and be like, man, what was the point of all that? I mean, I understand the drive of an athlete and everything. I just wish I would have been smarter and just not hid it from my parents, hid it from my coaches. And I wish I would have thought more long term, not just in the moment now, you know. I wish through all my concussions I just would have been more honest. I mean, I do miss soccer, but now when I think of soccer, I think of like pain. I miss feeling normal, yes. That's what I really miss. You know, don't be afraid if you can't go to school or if you have to give up that sport completely. It's gonna be scary and it's gonna really be tough, but you can get through it. You know, just don't compare yourself to other people because they haven't gone through what you have, and but that you can do it, and just keep being positive, and life is definitely worth living. You know, just make the best of it. That's what I would say.
So now you know a little bit about Tasha Helmick. Natasha was very helpful and instrumental in helping getting our state law passed here. So coming back to our question, in 2009, the first law was passed in the state of Washington. By 2010, other states jumped on board. 2011, quite a few states, including Texas. 2012, 13, only the Southeast remains. And by 2014, all 50 states had enacted legislation regarding concussions. Although the laws vary by state, so it's important to know where you're going to be practicing. Today we'll be focusing primarily on our state of Texas, but they have 3 commonalities. The laws have some component of education, requiring education on concussions, awareness and education recognition. They have criteria for return to sport or return to play after an injury, and they all require some sort of medical clearance. So our law here is known as House Bill 2038. Again, it was effective since 2011, and it applies to UIL schools, so public middle school and high school primarily, as well as charter schools. It does not apply to youth sports, recreational sports, club sports. Private schools that are not part of UIL do not have to follow this particular law. It is enacted into the TEA code now. So we're going to review some of the components of the actual law as well. I think this is important to understand our own law within the state which we practice. Each school district is required to create what's called a concussion oversight team, sometimes known as a COT. And that every school district's COT must include a physician. So it doesn't matter if you're a small school district out in a rural area in Texas, or if you're in a very large school district that has lots of resources. Every COT must have a physician. It must have athletic trainers if they are employed by the school district. They must be part of the COT, which is great because oftentimes they're the ones there managing the athletes. So it's great to have the collaboration of the athletic trainers as well. And now they've added, it may include any other healthcare provider. And so you have to have a physician, but you can have a nurse, a physician assistant, nurse practitioner, physical therapist, chiropractor, neuropsychologist. You know, in sports medicine, we're often a team, and so everybody brings something different perspective to the table. And when you're looking at the criteria and establishing your protocols for the district, especially those that are going to be helping manage these athletes, it is helpful to have everybody's input. The role of the COT is to help outline concussion management and return to play policies for that particular district. So the law has certain components that must be fulfilled, but each district can individualize it based on their needs, based on their student athletes. Part of the education component for our law is that students and their parents must review concussion information and sign a form acknowledging that they have read about concussions and understand concussions. And you know, the intent behind this, I think, is strong, but the effectiveness may not be as strong as we would like, because unfortunately this form is often included with many other forms that parents are having to fill out, and parents are just trying to sign and get through, and with the sports physical and every other form that they've got to get done just to allow their child to participate. So it often maybe doesn't get as much emphasis as we would like, and doesn't have as much of an educational impact. The law does require a training course every 2 years for coaches that are going to be coaching athletes in these schools. And any member of the concussion oversight team. I think one interesting component is that in general, physicians, unless they're a member of the COT, are not required to have continuing education in concussion. And I highlight that because a lot of those of us who are taking this course, for example, and are involved in concussion care are very up to date on the most current guidelines and recommendations of how to manage these. And sometimes physicians may not be as up to date as you are. As athletic trainers or other professionals taking care of these athletes, I think it is important to know that sometimes the physician who may be ultimately clearing this athlete may not have quite as much recent experience or knowledge. So sometimes it's helpful to have a conversation if things aren't quite going the way that you feel like they should be, or if it's not being managed the same way, and just kind of understand where they're coming from. It also the law requires immediate removal from play for any athlete believed to have had a concussion. It used to say suspected, and then they changed the wording to believed, which allows us to perhaps evaluate an athlete and determine that there was not a concussion that occurred, even though we might have suspected a possible concussion. We don't believe that they've had one after we've had a chance to evaluate them, and we can then return them to the contest. And it also allows for somebody to be treated appropriately and immediately safely. One of the catchphrases we'll kind of go through today, and you'll hear me say, is when in doubt, sit them out and keep them out. I think that this is one of those things that's sometimes a little bit hard to tell about a concussion early on, and so we always want to remove them, take a look, and do an evaluation. Continuing on with the components of the law, a student shall be removed from athletics, practice, or competition immediately if any one of the following persons believes the student might have sustained a concussion during the practice or competition. And so we've added, a couple of layers to this: a coach, a physician, licensed healthcare professional. So again, advanced practice nurses, ATs, neuropsychologists, PAs, chiropractors, PTs, school nurse, or the student's parent or guardian. And so I think that the emphasis of this is that anybody that knows that student athlete or that may have some knowledge about concussions, that sees something that concerns them, should be able to remove that athlete from play. We're trying to protect them. Sometimes they're not aware that they're injured. Sometimes they may choose to continue participating. And so our job is to help protect the student athlete. And so sometimes that's helpful. The more people that are kind of watching out, the better off we are. It also requires a progressive return to play once they're completely asymptomatic, and it must follow guidelines. So we'll go through this a little later in the talk. And then it requires, in our state, in the state of Texas, it requires a signed clearance by a physician. So again, in Texas, a physician is defined as a MD or a DO. Lots of other states, as I said, have differing components of who may clear an athlete, but this does not allow anybody besides a physician to ultimately determine written clearance for a student athlete. So I think that's a big point of emphasis for a take-home for our state. So we talk about guidelines. There are a lot of guidelines out there, and so I've just included a few here to kind of give you some idea, and we'll go through some of these as well, but the CDC, the NATA, the American Academy of Pediatrics, the American Medical Society for Sports Medicine, and what we call the CISG, or the Concussion in Sport Group. So there's international, there's American, there's pediatric, there's lots of different guidelines. And so as things evolve, the guidelines are updated and changed, but fortunately, there tends to be a lot of overlap and a lot of agreement between most of these consensus statements and guidelines. So the concepts are fairly similar. So when we talk about the International Consensus Conference on Concussion in Sport, or the CISG group, and so this is sometimes referred to as the consensus statement. What they've been, every 4 or 5 years, a group gets together and the latest research is presented. And so these are typically people that are fairly prominent researchers internationally, concussion experts, clinicians, researchers, scientists, get together and they will review what is the latest literature and research that has come out since the most recent guidelines. And then they will break apart into groups and rewrite the guidelines in each little component, again, trying to make it as evidence-based, scientific-based, based on the latest literature and updated. So fortunately, they got to meet just recently. It was about last year, October of 2022, and Amsterdam. They get to go to pretty cool places usually and get together, but then there's a lot of work that gets done. And so we'll be highlighting some of the updates from the sixth consensus statement today. So the definition of concussion, just to kind of get all on the same page, and sometimes these are a little bit hard to define, so we'll use the definition from the consensus statement, the sixth consensus statement to be specific. So what is a sport-related concussion? A sport-related concussion is a traumatic brain injury caused by a direct blow to the head, neck, or body, resulting in an impulsive force being transmitted to the brain that occurs in sports and exercise-related activities. That's what we're talking about today. Certainly you can have concussion outside of sport, but most of the patients and athletes that we see sustain injuries while they're participating in their sport. This injury initiates a neurotransmitter and metabolic cascade with possible axonal injury, blood flow change, and inflammation affecting the brain. It is a brain injury. Symptoms and signs may present immediately or evolve over minutes or hours and commonly resolve within days, but may be prolonged. No abnormality is seen on standard structural neuroimaging studies, such as a CAT scan or an MRI, but in the research settings, some of the neuroimaging that we're starting to do may start to see some abnormalities. Sport-related concussion results in a wide range of clinical symptoms and signs that may or may not involve loss of consciousness. In fact, the vast majority of patients who have sustained a concussion do not lose consciousness. That's an old myth that you have to be knocked out to have a concussion. Signs and symptoms of a concussion can't be explained by drug, alcohol, or medication use, another injury, or other comorbidities such as psychological or other medical condition. So basically saying it makes sense that what we're seeing is caused by the injury. So how frequently do we see concussions? A lot of us that take care of athletes know that this is a common injury. So we're talking millions of these per year in the United States youth alone. And those are some of the ones that are reported. There may be more that are not reported. So we talk about, for example, in high school, and here in Texas, football is very high. We see a lot of football injuries. But girls soccer is a close second. And I would say that our experience here at Scottish Rite is, and certainly here in the North Texas region, soccer is huge. We see a lot of girls soccer players with concussions. Other injuries as well, but it's certainly true. And I think that, again, we've put so much emphasis on football, but we neglect the fact that this happens in females, and it happens in lots of other sports as well. So girls soccer, you see the incident rate there versus boys soccer. So it's about twice as much in the girls as it is in the boys. And then if we look down, for example, at basketball, again, about more than twice as much as it is in boys. So girls have a higher rate than boys in comparable sports, and there's lots of reasons and theories about why that may be. But again, I think it's a point of for us to pay attention to is that we need to focus on all of our athletes and not just football. This is a document that I think is an example of something that you could utilize. This comes from the Kyle group and is what we call a medical timeout. And I think a lot of us that cover, for example, football games go through this, but you could do this with any sporting event. And the concept is that we like to prepare before an injury happens and before an event starts so that we all know how we're going to respond in the event of an emergency. So a concussion is not always an emergency, but it can be associated with lots of other things. And so I think utilizing something like this, making sure that everybody that's covering there on the medical team, is in communication, if you have EMS there or there's administration, what everybody's roles are going to be, sort of like your emergency action plan. So this is kind of part of that, going through that. So this is a good resource and is accessible for free online. If you go to their website, you can download their PDF. And again, I think it's fairly helpful. Okay. So we're going to move on to a little quiz. We're going to test ourselves and see how comfortable we are with some of these symptoms and signs of a concussion. So again, if you are online, challenge yourself. If you are here, we're going to do this by show of hands. So please indicate which of the following you would consider to be a sign or symptom of concussion by raising your hand. Okay, so who thinks abnormal sense of taste? Is that a sign of a concussion or symptom of a concussion? No. What about amnesia? Is amnesia a sign or symptom of concussion? Yes. Blurred vision. What do you guys think? Yes. What about a black eye? No. Bleeding from the ear? No. Bleeding from the nose? No. What about a fever? No. Headache? Yeah, lots of hands on that one. Okay, good. You guys got that. Insomnia? Yes. Sleep issues. Nausea? Yes. Numbness or tingling of the arms? No. Skin rash? No. Sharp burning pain in the neck? No. Weakness in neck movements? No. So we went through these, and there was a study that was done that kind of asked some of these symptoms to 1,300 athletic trainers that are members of the NATA. And they surveyed them, trying to figure out how knowledgeable athletic trainers were about concussion signs and symptoms. And the average score was about a 78. So athletic trainers had adequate concussion knowledge and familiarity, they found, with concussion guideline publications, not just signs and symptoms. And if you can look there on the right there, it shows you about how many kind of got it right or wrong there. So for example, headache, 98.7% of people got it correct. So they did notice that years of experience influences your assessment and management. And it's actually the opposite of what you might think, meaning that the longer you've been around, the less likely you are to be using the latest guidelines. And so part of the reason we're sitting here today is to help update and make sure we are utilizing the latest guidelines, we're up to date, following things, because it is easy if you've been in practice for a long time to rely on your experience and to remember what you were taught or what you were doing when you first came out of training. So constantly challenging ourselves to stay up to date is important. With the latest consensus statement, we have updated guidelines, and so we're gonna review some of those today. The CRT-6 is the Concussion Recognition Tool version 6, essentially. The 6 is just telling us which consensus statement it came from. So this is from the 6th consensus statement. So we're in the SCAT-6, for example. The previous version was the SCAT-5. So these are designed to be used by essentially sort of the lay public. And the SCAT-6 is more for healthcare providers like us, but this is great for coaches or parents or others that, officials who may not have the healthcare background that a lot of us do. And so this is something that I think is helpful, is to watch out for, again, clues of a suspected concussion. Obviously, if somebody gets knocked out, I hear all too commonly that an athlete lost consciousness on the field, everybody evaluated them, and then they were allowed to return to play. That should be a very easy no-go, that they don't go back to play on that. But even that clear sign is often allowed to go back. So if they're lying motionless, if they fall unprotected, they're disoriented, they have a dazed look, obviously if they're having a seizure, that's concerning. If they're slow to get up, unsteady on their feet, facial injury. So lots of these different things. And then these are some symptoms for people to look for. Just like we talked about briefly with the symptoms in that most recent one, headache, pressure in their head, balance problems, nausea, changes in emotions, changes in thinking. A lot of times, again, the people that are out there, whether it's a teammate or it's a coach or a parent, they know the athlete pretty well. And so something is off, then that's a good time to pull them off and evaluate them. Then we can ask them some questions. Awareness, these are sort of sport-specific questions, what's known as the Maddox questions. Where are we today? What game are we playing? Who scored last? What team did you play last week? Did you win last week? Things that an athlete should know. My thought is that usually if you're kind of getting to this point with an athlete and you are not a healthcare provider, and you're worried enough that they might have a concussion that you're starting to ask them questions about if they know where they are or not, you probably shouldn't be returning them to play. You should probably, again, when in doubt, sit them out and keep them out. Now, again, I think as healthcare providers, we'll talk about the SCAT-6, we may make a determination once we get a little further down the road, but I would not rely on an athlete's ability to tell me that they won the game last week to determine that they do not have a concussion, and I feel confident putting them back in, because that's a pretty low bar to set. So again, when in doubt, sit them out, keep them out. Remove them from play. You want to make sure that they're evaluated by a medical person. And so if the athletic trainer's not there or there's not somebody there, I do think they should be evaluated. I don't know that the parents and the coaches should be making the medical decision there. That doesn't mean that I think that they can make the decision not to go back to play, but the athlete needs to be evaluated by a healthcare professional. Oftentimes, middle school, high school, for example, the parents may not be there. Practices, especially in-school things, but even games, away games especially. So it's really important to communicate with the parents. Make sure somebody from the school, preferably somebody from the medical side, whether that's the athletic trainer or the team physician, or somebody, if not at least the coach, notifies the parents, gives them a heads up, even if you're not sure that the kid has a concussion, or even if you think they don't have a concussion. I think it's always better to err on the side of being more communication. Parents get really frustrated when they come in and they find out from their kid that they had an injury, and they feel like, for some reason, they feel like the school may be trying to hide something. And it's not the case. There's just so many other things going on, the communication may get dropped, but even sending home a piece of paper, if you just make an effort to try to call them if you can, or communicate with them however you can, I think it's really helpful. Say, hey, this is what happened to your kid today. These are the things to watch out for. This is what we observed. This is what we're concerned about. These are your next steps. And that goes a long way in everybody being on the same page. Keep them out of play. They don't go back the same day. When I was in training, we would very commonly return athletes to play the same day if their symptoms resolved within that same contest. So things have changed. We don't do that, whether it's the youth level or the professional level. If they have a concussion, they do not return that same day. So moving on to the actual evaluation a little bit now, we're on the medical side of the evaluation. We've gone beyond sort of that recognition. There's some suspicion of an injury, and we want to pull them off to evaluate them. So as I said, the SCAT-6 is the newest version that's come out just recently here, and the child SCAT-6 there. So we want to get a good history. We want to do some sort of a symptom scale. A lot of our student athletes or athletes, if we ask them, how are you feeling? They may tell us they've got a headache or a tummy ache, but they're going to have a hard time telling us, I'm having a little bit of difficulty focusing, or I'm a little bit irritable today. They usually don't tell us that. Or you may get, how you feeling? Fine. That's about all you may get out of them. So asking a little bit more symptom scales, I think, is really helpful. It also helps us track their progress. So you know how they felt at the time. Are they getting worse? Are they getting better? Maybe their symptoms were okay, and then they go back to school, and all of a sudden their symptoms went way up. That's helpful information for us to have. You want to do a good physical exam, a neurologic exam, balance and vision and balance and vision and motor, what we call a vestibular ocular motor screen, I think, are also really important components that might provide some objective data to us in terms of our concussion evaluation. You want to do some sort of neurocognitive testing, looking at the brain's function, as well as ultimately some exertional testing. So as I mentioned, there's the SCAT-6 and there's the child SCAT-6. The SCAT-6 is designed for ages 13 and up, as well as adults, and then the child SCAT-6 is for ages 8 to 12. So there's not really a whole lot for the really young kids, but for middle school and high school, we certainly have some options that are here you can utilize. And this is more, the SCAT-6 is more to be used within the first few days after the injury. It can be certainly a sideline type assessment or training room assessment, clinical assessment. They've also come out with what's called the SCOAT-6. This is new with the 6th edition. We have not had a SCOAT before, so there was never a SCOAT-5. The SCOAT-6 is office-based, so perhaps if they go see their physician, then they may do a SCOAT-6. It's got a little bit more depth to it, but the SCAT-6 is probably appropriate for most of our purposes in terms of the acute evaluation and training room evaluation. So I do want to go through the SCAT-6 a little bit. Many of you may already be familiar with it. You may utilize the SCAT-5. There are some subtle changes to the SCAT-6, but if you're not utilizing this, I think this is something that a lot of athletic trainers have that experience to recognize this is a concussion. He or she is concussed. I know what I'm doing. I'm pulling them out. I'm not putting them back. I've made the diagnosis. I kind of know the things to look out for, and I'm initiating my concussion protocol following my school district's protocol. But sometimes there's not that next step of actually doing more of an evaluation to kind of have us look into things because they feel like that determination has already been made. But I think it really is helpful to do that next step and kind of go through everything to have more information, both for triage purposes, but also for the assessment. So for example, for me, when I see patients, sometimes I'll see them a few days later and they will tell me, I was fine. I didn't have anything. Or maybe I just had a headache that lasted for about 15 minutes, and after that I was completely fine. So sometimes it's really hard for us to determine, was this a concussion or not? And then I may talk to the athletic trainer, and they may tell me, oh, no, she was so confused. She didn't remember where she was. She was unsteady. We had to help her off of the field. And by about 30 minutes later, she looked way better. Well, that's a very different story than I only had a headache for 15 minutes. And so that information can come out in the SCAT-6 if you can provide us some objective or information there to kind of go on. So starting out with the first page of the SCAT-6, it kind of goes through a little bit of a triage of red flags. And the red flags are in that box there. These are things that might indicate there's something besides a concussion. Whether that's a cervical spine injury, a skull fracture, a brain bleed, perhaps something that's more serious, more urgent or emergent than the concussion that we don't want to miss and we don't want to overlook. So you go through the red flags, and these are essentially patients feeling worse, anything where they can't move arms or legs, when it says loss of consciousness, I would probably say prolonged loss of consciousness, perhaps longer than a minute. If they are just briefly knocked out and by the time we get out there onto the field, they're already coming around, that is not necessarily a big red flag to us. Same thing with vomiting. They vomit once. That's not uncommon, but if they keep vomiting, more concerning. So we want to do any of those, any red flags, you kind of stop and you move on immediately to triage, and do I need to transport them, activate my emergency response system, get EMS involved? And if the answer is no, then you start to kind of go through the next page that we'll go through. And each one of these it kind of allows you to a checkpoint. So first is, again, the emergency referral. If yes, do we need to send on? Then the observable signs, as we talked about briefly with the concussion recognition tool, the Glasgow Coma Scale. And one of the nice things about the SCAT-6 is you don't have to remember all of this. It walks you through it. It's pretty self-explanatory. There's actually a separate document that has detailed instructions on how to administer it. So if you forget or if you want to study it before because you're going to be doing it consistently, it's very well written in terms of helping you kind of know exactly what you're supposed to doing. So there's a lot of clarity there. They want you to do a cervical spine assessment, looking for any sort of a neck injury in through there. You're going to do a kind of a brief coordination and ocular motor screen, and then doing the memory questions, the somatics questions we talked about. We're just trying to get a sense of how injured is this athlete, and am I okay to spend a little bit of time continuing on? This can be done pretty quickly, pretty briefly, just a rapid screen. Then we can get them off the field. We can start to do a little bit more of a detailed assessment, finding out about their history. Have they had any injuries in the past? Are there other things that are going to set them up for longer recovery? And then we go through the symptoms. So it says here, hand the form to the athlete. You want them to kind of help walk you through. Do they have the symptom? And if so, how bad is it? That not only, again, lets us kind of make determinations on the injury, but also, are they getting worse? Are they getting better? Which direction are they heading there? So it kind of goes through the different 22 symptoms, 0 to 6. 0 is none, 6 is really severe, and the athlete can rate themselves on that. Then we move on to some orientation questions. What month, day of the week, is it, what year is it, what time is it, more or less right now? Do they know where we are orientation-wise? Then we move on to immediate memory. One of the changes from the SCAT-5 to the SCAT-6 is we've gone from a 5-word list to a 10-word list. And so if you thought 5 words was hard, 10 words is really hard. And I think part of this is where this might be helpful if you have a baseline on your athlete, knowing kind of what's normal for them. And a lot of times you have a good feel for your athlete, but it's hard for us. And 10 may not be the expected normal for these, right? They're not going to probably get 10 out of 10 on these, but you kind of go through these words one at a time. Jacket, arrow, pepper, cotton, movie. And you ask them to kind of come through and give you the words back. And go through that 3 times. Then we move on to concentration. Now we're doing some focus and allowing them to work on some sort of numbers backwards. So for example, if I say 493, they'll say 394. They would go in reverse order. They've also gone up to 6 numbers backwards on this, so this goes up a little bit here. It gets more and more challenging and makes it hard for them, again, kind of knowing how well they're able to focus there. Again, knowing what the baseline for your athlete, because some of our athletes may struggle doing 3 or 4 numbers backwards, even at baseline pre-injury. We have them do the months in reverse order as quickly and as accurately as they can, starting with December, November, October, September, and they kind of move through things. And then we'll move on to the coordination and balance exam. We utilize what's called the MBES, or the Modified Balance Error Scoring System. This is essentially 3 different tests, 20 seconds each, looking at their balance. In the younger kids, we take out the single leg stance, but in the SCAT-6, we'll use all 3 of these. This is ideally to be done barefoot. You can't have them in their cleats on the turf as well. Now, again, if we're just trying to do a quick screen, you may do what you can. You want to kind of document what they're wearing and where they are. But when we're really trying to determine, because you get a lot of what we call proprioceptive feedback from the skin and the foot and the surface, so a hard surface as opposed to a soft surface, because when we want to challenge them, we can actually add foam. So if you're on a really soft turf surface, that makes it a little bit more challenging than maybe a rigid training room floor, for example, there. And we're assessing the number of errors and kind of what their balance looks like. You can also do a tandem gait, where you have them walk toe to heel about 10 feet down and back, and time them for that. And then you can also, if you really want to challenge them, start to have them do some counting backwards while they're actually doing the tandem gait. So we're trying to kind of really push them, make their brain work. So if you think about in sport participation, we're having to do a motor task. We're moving. We're going to, run to a ball, focus on a ball, while we're simultaneously looking at players coming in and trying to process information and make decisions while we're actively moving. So that's where the dual task comes in, is we're trying to challenge the brain a little bit in terms of thinking while acting and moving. So then we'll move on to the delayed recall. Now we've done all of that, and we will ask them to recall the words that we had given them on the list earlier and see how many of those words that they can get. Then you add up all of these, and you'll come up with a total score. Then at the end, it says disposition. You can say concussion diagnosed, yes, no, or deferred. And sometimes, again, it's very clear that they do have a concussion. Sometimes you can come up with an alternative diagnosis. Maybe they got hit in the nose, their eyes got a little watery briefly, they had nose pain, maybe a little nosebleed, but never had any other concussion symptoms, and they feel fine, look fine, everything looks really pretty good. We feel like this was a nasal injury, not a concussion. There's lots of things that can kind of occur, but you maybe, if you say no, you'll be able to have to figure out, why, what else, what happened then. And then sometimes you'll say deferred, which means I'm not sure yet, I'm worried, but I can't rule it in, can't rule it out yet. And that's not uncommon as symptoms sort of evolve. There was enough of an injury there, enough of a concern, but they're not, you can't make that definitive, again, diagnosis. I know in theory, we're not supposed to be diagnosing on the sideline as athletic trainers, but the concept is, are we putting them in the protocol and kind of going to keep them out of play, or are we going to return them back at this point? So that's the SCAT-6. I think it's a good way to kind of go through some of the evaluation and kind of in a organized fashion and a systematic way. It also allows you from a medical legal standpoint to protect yourself, to make sure that you have evaluated. I think that if you have that and you can kind of come back and say, hey, look, everything on here looked really good. That was part of the reason I made that determination on allowing the athlete to go back. This athlete did have something. I did not send them to the ER. They didn't have any red flags. Their SCAT-6 looked really good. I gave the family the warning signs for what to look for. So I think it's also nice to, again, like I said, have some sort of documentation that you did an exam on the athlete there. So how do we manage these? There's been a little bit of a shift from this just complete rest, shut them down, to more of a symptom-limited activity, meaning basically if it doesn't make them feel worse, it's probably okay as long as it doesn't put them at risk of getting hurt again. So we're not going to put them back in a soccer game while they're still injured, but we might be able to get them back to school. We might be able to get them back to doing some other physical activity and some things that are a little bit, again, doesn't make their symptoms worse. So we'll talk about the physical side here and kind of in depth, because I think that's a big important point that I would like for you guys to be kind of make some progress, move in a little bit of a different direction than what we've done historically. And then cognitive rest. There's a big focus on what we call return to learn, getting them back into school. And I'm focused, I typically tell families that I'm focused on your injury and your health, and healing is my priority. School is sort of second, and sports is kind of third. Oftentimes theirs is completely flipped for me. They're like, when can I go back? When can I go back? That's all they care about. So, but I want to get them back into school. Make sure their brain is tolerating school days, and that cognitive exertion. It's not uncommon for us to see an athlete injured, Friday or Saturday during a game, and maybe not really be all that symptomatic during the weekend. They think that maybe they're kind of in the clear and didn't have a concussion, and then Monday they go to school. And by second or third period, their symptoms are really bothering them as they have tried to actually use their brain. So I liken it to an ankle sprain. If you have an injured ankle and you're sitting on the sofa, it probably doesn't hurt as much as if you get up and try to walk or run on it. Same thing with a concussion is if you're not utilizing it and you're not making that brain work, then it's not going to be as symptomatic. So we see that come out at school. So they need to make sure that they can tolerate school before we allow them to get back into things. And then as they start to feel better, we start to let them do a little bit more as their symptoms improve. Sleep is really important, and sleeping adequately 8 to 10 hours at night, but also not sleeping all day. Sometimes they're so tired they come home and they sleep all day, and then they get their sleep schedule mixed up. So we want them sleeping adequately, but not on a normal schedule. Driving restrictions, I don't like, teenagers may not be the best drivers to start with, a little bit high risk, and then if they have a concussion, even more high risk. One common thing that I will encounter is that an athlete has been diagnosed with a concussion or a suspected concussion, pulled out of practice or a game, and then allowed to drive home from school or drive home from the practice. So if you're worried the athlete has a concussion, please don't let them drive home and don't let them drive, have them get rides. The AMSSM had come out with what we call clinical profiles, as opposed to it just being single symptom-based. Start to think about sort of groups and different groups of symptoms, so to speak. And a lot of times athletes will have kind of one or more of these profiles. So they may have sort of a vestibular and a headache profile, or they may have kind of a fatigue and a cognitive profile going on through there. And so sometimes knowing where they're falling helps us target and individualize our treatment to that athlete based on what's bothering them the most, because not every concussion is exactly the same, and so we have to kind of individualize our management to them. And so this is one way to kind of group and think about that. So we talked about cognitive rest. Again, not long ago, it was kind of this, lights out, stay home, rest, dark room, no electronics. And we found that those who really do a lot of strict rest actually take longer to recover, and they feel worse than those who just kind of rest until they feel a little better, then get back into things. And now it's those who didn't rest at all also take a little longer. So it's not all or nothing. It has to be kind of a graded. Again, that's symptom limited. So oftentimes if they say, I'll ask them on a scale of 0 to 100, with 100% being normal, I feel back to normal the way I was pre-injury, what percentage of normal do you feel today? They say, I feel 50% of normal. I'm half of my, my normal self. Okay, well, you can probably do about 50% of your coursework and your schoolwork. So maybe we need breaks throughout the day. Maybe we do every other question on the homework, those kinds of things. But we don't need to have you doing 0%, and we also don't need you doing 100%. And then as they start to feel 70%, we can let you do a little bit more. There are several different guidelines, and I think depending on your setting, it's great to work with the schools and find out what they have in place. Oftentimes there are education coordinators or counselors or nurses or learning specialists. Every district has somebody different, and so whatever, depending on your resources, somebody that can help manage the academic adjustments and accommodations, modifications in the classroom for the student athlete. And notify the teachers and kind of help them progress through this. But we try to give some information to the teachers about what's going on with this particular athlete. You can make some modifications based on what their symptoms are. So this is coming from the return to learn progression. Here is the most recent one, and you can kind of also, just like we have a return to sport progression, we've got return to learn. We progress them back gradually. So first step, we're just trying to get them back to typical activities that don't make them feel a lot worse. Second step, school, and we're kind of getting them back into a little bit of cognitive work, and then we're kind of back in school part-time, then we're back in school full-time. I try to get them back to school after no more than maybe 2 to 3 days of rest from the injury. After that, they really start to fall behind. They start to struggle, mentally, just the stress, the kind of the isolation of not being at school, and then again falling behind. It's really, really challenging for them. And so again, they may be there for a full day, but not doing a full amount of work. And so we can modify things quite a bit for them while they're there. Based on their symptoms, we'll also modify. So for those that are having noise sensitivity, maybe they need some earplugs to allow them to tolerate the classroom and or the hallway during passing periods. Or if they're real sensitive, maybe they don't go eat lunch in the classroom, in the cafeteria. Or maybe we let them out a couple minutes early so they can kind of get to their next class before they're in the noisy hallways. So there's a lot of different things we can kind of individualize based on their actual symptoms in the classroom setting while the athlete is recovering, allowing them to get back into things. So physical activity, again, I do want to focus on this because I think that this concept is continuing to progress, but a lot of the athletes that I'm seeing and that come in with a concussion are still completely restricted from the time of the injury till the time that they see us, even if it's been a week or two from the time of the injury. And so I do want to kind of talk a little bit about this. So there's been a lot of good studies that have come out. We know that forcing somebody to exercise is probably not good, but allowing somebody to exercise is not harmful. And again, we think that staying completely restricted from physical activity for a prolonged period of time may actually be harmful. So if exercising is not harmful, but resting too much is, then it makes sense we might start to get them active again. This was a good study that was done by Dr. Leddy and his group up in Buffalo, and they randomized teenagers to either subsymptom threshold exercise, aerobic exercise. So we're not talking about running sprints and lifting weights and doing full strength and conditioning workouts. We're talking about getting them on the exercise bike, doing some easy jogging, just getting their heart rate up some, pumping some blood to the brain, allowing that autonomic system, the cardiovascular system, to start to recalibrate, and allowing them to get some exercise. Again, these are mostly athletes that are used to being physically active. We all know that there are benefits to exercise. There's endorphin release. It helps with their metabolism, helps with their energy, helps with their mood. And so we want to take advantage of all of those benefits of exercise, plus the fact that there may be some help to the injury, and utilize that to help us. So I have athletes oftentimes that are very tired, and we start to get them back on a little bit of an exercise program, and all of a sudden their energy comes up, even though they're exercising. They're not getting more tired, they're getting more energetic. They have less fatigue, so they feel better. So this study looked at that and found that those that were in the stretching group were actually more likely to take longer and have a prolonged recovery versus those that were put into the aerobic activity group. And so they decided that subsymptom threshold aerobic exercise during the first week after sport-related concussion speeds recovery and may reduce the incidence of a delayed recovery. So I would encourage you to, once you get past that first maybe 24 to 48 hours of initial assessment and rest period, get your athlete back exercising. I think it's safe. I think it's helpful, beneficial in the recovery mentally, physically, and in terms of the injury itself. There's some science to back that. So try to get them on the bike, maybe 15 or 20 minutes, nice and easy. Just get on the bike and kind of do things if you have access to that. The reason I keep talking about the bike, if you have access to an exercise bike, a lot of times we will see either cervical injuries, so a little bit of a whiplash injury, or we will see some vestibular or oculomotor, so balance or vision issues related to the concussion that are persisting after the actual event. And if you are out jogging, for example, and your head is moving around, if you have any of those, that might exacerbate symptoms. Whereas if we put them on a stationary bike, they can move their legs, there's less head movement, so they may be able to better tolerate that. That doesn't mean that jogging is not safe, but most athletes can tolerate the bike and some may not tolerate jogging. So depending on what resources you have, if you have access to a bike, that's a good thing to start with and allow them to see if they can tolerate that. So, again, lots of data coming out. This is from the Journal of Athletic Training. Says aerobic exercise is safe and well tolerated by pediatric patients. Introducing aerobic exercise early as part of a treatment program doesn't increase risk of longer recovery. It supports the use of early exercise to lessen symptom burden or expedite symptom resolution. So the things we want to hear: it's safe, it's likely to get them better faster. And clinicians should use a validated protocol that offers the greatest possible benefit. So there are some things out there, again, that came from that same article looking at how do you do it, how do you progress back. But just start low, go slow, see what they can tolerate. If their symptoms get a lot worse, then we need to back off a little bit. So coming from some of the other guidelines, the American Academy of Pediatrics and the CDC, again, have emphasized this point. So I say this is new, but these are from 2018, and at that time, they were already recommending exercise. So this is at least 5 years old that some of this is out there, but I think a lot of us are still hesitant to get the athletes starting moving, so that's why I would encourage you to push, if your concussion oversight team and your guidelines require medical clearance to start any light aerobic exercise, I'd suggest looking back at that and seeing if we can get that changed so that, to me, this is part of the treatment. This is not their return to play progression. That's a separate deal. This is part of their treatment, is getting them exercising early on. So again, no more than 2 to 3 days of rest. The other thing is that prolonged removal from school can have negative effects on recovery and symptoms. I saw a patient this week that, he had been told by his primary doctor to stay home from school and to not do any electronics and not do anything. Again, kind of the old school way of doing things. And I saw him, by the time they called us to come see us, he actually was already about 2 weeks out from his injury. And so when I told him that I wanted him to go back to school, he had a huge smile on his face. He's like, yes, I can go back, because he was not doing well at home. And so that's where we want to get him. We want to get him back to their life as quickly as possible, safely. So moving on to return to sport, in terms of getting them back, like we said, they don't go back the same day. They don't go back until we say they're asymptomatic. That doesn't mean they have to be completely symptom-free. That means they have to be back to the way that they were prior to their injury. And so if I have a teenager who tells me that they're a little bit tired, or maybe they have ADHD and they have a little bit of difficulty focusing, or they have a history of headaches and they have a headache, that's okay. We're trying to figure out what's normal for that student athlete, get them back to that level. So if they're not putting all zeros on my SCAT-6 symptom scale, that doesn't mean that they're not recovered from their concussion. That may be that they're being honest with us and telling us actually how they feel that day. Once they're cleared, again, in our state requires physician clearance. They can go through a gradual progression. Each stage typically takes about 24 hours, so 1 day per stage. And then what we're monitoring for is symptoms during or after exercise. As they progress back, we want to make sure that their symptoms don't come back with activity. So most of the time when they're cleared, they'll do fairly well. These are the latest return to sport guidelines from the 6th consensus statement. So again, symptom-limited activity. We start off getting them back in school. Then the light aerobic exercise on a stationary bike or walking. You can do light and to moderate, and we're just trying to get their heart rate up a little bit. Then we can add in some individual sport-specific exercises, maybe kind of running, some conditioning drills. Now we're adding in a little bit of head movement, direction changes, then non-contact training drills. So maybe we're adding a ball now. So if you're a basketball player or soccer player, maybe this is passing and shooting drills. We're adding a little bit of hand-eye coordination, starting to think a little bit of cognitive function in through there, getting them back into condition where the level of exertion is up a little bit. I think one thing that we often have to think about is heat. Here in the state of Texas, it's been really hot, and we've had a lot of issues with that. And so if your athlete has been out for a while or only training indoors while they're rehabbing from their concussion, they may need to go through a little bit of an acclimatization period from their heat as well. So maybe getting them to start doing some of that outdoors, make sure they can tolerate the heat. And then we get them back into practice. And then once they've practiced, they can go back to games and competition and through there. So you don't skip stages. You can't do 5 stages in 1 day. So if I'm seeing somebody on Wednesday and they want to play in the game on Friday, well, that's probably not likely if they have been shut down, because we're not going to get through 5 stages in 2 days. Okay, we'll take a little break, and then we will come back and continue for part 2. All right, so we are going to continue our concussion knowledge day here, and hopefully move on a little bit. I'm going to start by kind of summarizing some of the things that we talked about in the first, and going through some of the guideline recommendations. So we just make sure we have these before we leave today, and then we'll talk about some of the newer research and changes. This is from the CDC guidelines. Again, I think we talked about this, but we don't want to get imaging on everybody, especially CAT scans. There's a lot of radiation with CAT scans, and so it's not something that we take lightly, especially in the pediatric population. I think a lot of the pediatric facilities, like pediatric emergency rooms, they're pretty aware of this. But if you go to an urgent care or an adult ER with a concussion, you're likely to get a CAT scan. Even if you don't need it. And so there's been a point of emphasis to try to help educate people that are making those decisions. And I think, again, a lot of times athletic trainers are pretty good at knowing, right, this is what I'm worried about. Maybe we do want to send you on, but not everybody needs to go get imaging. We do want to use the symptom scales that we talked about. Looking at risk factors for prolonged recovery, we'll talk briefly about this afternoon as well, or this morning. Now, and then we're going to get them back after, again, no more than 2 to 3 days of rest. This is from the American Academy of Pediatrics. We're just going to highlight a few of these. Again, imaging is usually normal, so we don't want to image everybody. We want to reduce them temporarily, but longer restrictions are not good. And then we'll talk a little bit more about long-term effects, but both the AAP and the newest guidelines, there's a lot of discussion about CTE and kind of the long-term effects and such, but the consensus statements continue to sort of say, we still don't really know exactly what's going on and what that means, and so we can't definitively say that there's a connection in there. Currently, no medications have been developed to prevent or treat symptoms of sport-related concussions, and there's no really significant quality studies that demonstrate benefit in concussion recovery. So we certainly use medication for symptom management, but unfortunately there's not a great medicine that has a lot of data to support it. And then retirement is always going to be an individualized decision, and those are conversations that you want to have. Make sure that you have a good multidisciplinary team if you're talking about retiring an athlete from their sport. And if we do recommend that they retire from one sport, we want to make sure we provide alternative sports for them because there are so many benefits to sport participation. So what else can they do? We didn't talk a whole lot about neurocognitive testing. There's computerized neurocognitive testing is one tool. There's a lot of brand names out there. Impact is the most commonly used test in this area. There are multiple others, CNS vital signs, SWAY, Dana. There's other ones that are out there, but it's something that we do utilize, but it's not our only decision-making tool. So it's not that they pass their test so that they're not concussed, or that they pass their test so that therefore they are cleared to go back. And then I think we've talked quite a bit about pulling them out immediately, and if it's during the school year, we want to make sure that they're tolerating full school before they can go back to sports. So again, I may have them active and doing some non-contact training, but if they're still have academic accommodations in place and they're not able to do a full academic load yet because of their injury, then I'm not going to clear them to be in a basketball game that night if we feel like they're not recovered from their concussion. Now, I clarify that the difference would be is if I have an athlete who's fully recovered, has no accommodations, but yet maybe they still have some makeup tests to do, I don't require them to have made up all of their missed work. If they're behind, I'm not going to hold them out for another week or two while they're getting caught up on tests. But if we are still saying, you know what, they're not able to do a full workload, they're not ready to be playing their sport yet. From the NATA, some of the highlights that they want to hit for the athletic training community is again talking about the status. Communication I think is important on a regular basis. At least in our world, oftentimes I'll see them once or twice. I may see them at the time of the injury, I may see them at the time they're cleared. But the athletic trainers are managing them and seeing them on a daily basis, if not multiple times a day. And so you have a lot of insight and valuable information that you can provide that may update that. And things may change very, very quickly between the time that we see them and the next time that we see them a week or two later. There's a big change, and we may, again, increase their physical activity, increase their academic load. Talks about baseline testing. Baseline testing, I think, is valuable if we have access to it. There, how much you do. So, for example, again, the breakout we'll talk about the SCAT-6 has been proposed as you could do a baseline SCAT-6, but it also says that to do it right takes 10 to 15 minutes, and so it's a challenge depending on your setting. If you're working in a professional team setting, that may be realistic to do that on all of your professional athletes in the preseason. But if you are, maybe one of two athletic trainers covering a large high school with hundreds of athletes, it's really challenging. So what can you do as a baseline? But baseline is helpful if you have it. Sometimes the baseline to me is you know your athletes better than we do often, and so one of the questions on the SCAT-6 is if you know the athlete, are they different than their normal selves, and that's another important baseline to have there too. They want you to use some sort of home instructions. So again, sending information once you have an athlete that's been diagnosed with a concussion, sending home some information, whether that's the Scottish Rite form or whether that's something from the consensus statement or the AAP. There's different forms out there, or you have your own school district as part of your concussion oversight team. Oftentimes we'll have something that you've created that you can share, but I think that's very important to again send them home with some information. And the newest consensus statement also sort of says this, Tylenol or acetaminophen is probably fine early on, but we want to avoid aspirin, we want to avoid alcohol, we want to avoid other anti-inflammatories, ibuprofen, things like that early on. Usually after 24 to 48 hours, I'm okay with it. There's a theoretical increased risk of brain bleeding, and if you have a little small bleed, and then the anti-inflammatories may increase that risk. So that's the reason that people say to stay away from them. But I think it's certainly fine to recommend some Tylenol for their headache. I think there's a common myth that you need to wake up the athlete. And so this will happen a lot where parents will come in and see me, they got concussed the day before, and then they all night have woken the athlete up every hour or multiple times through the night, and they come in and both the parent and the child are pretty miserable because nobody got any sleep last night and they have a concussion. So please don't do that. Let them sleep. If you feel like, I always tell the parents, if you're not comfortable letting your child sleep through the night, then you probably need to go to the emergency room and get them checked out. And so if you're going to be that worried that you feel like you have to wake them up because they're that bad, then that's when you have them go get somebody to check them out. Because a lot of times they may or may not have been checked out already, but we don't want to do that. It's good for them to get some sleep. And again, the NATA highlights that. And then the grading scales, you haven't heard me talk about grading scales this morning because we've kind of moved away from using those for over a decade now. But some people still use grade 1, grade 2. We used to do simple and complex, but really you're concussed or you're not. And I think that it's not as helpful for us. There's other things we can look at that help us decide how long somebody's going to take to recover. All right. So we'll move on. I borrowed these slides from Dr. Ellis. But I thought this is a good concept to talk about, not just for concussion, but just in terms of return to sport in general. But I think specifically for concussion, it is helpful. This concept of psychological readiness to return to sport after injury. Here we have two athletes, about the same age, same sex, playing the same sport, both injured the same way. Both got a concussion going for a header, collided heads. But they may not return to sport in the same way. And even if they have the exact same injury, everything else is the same. So there's this concept of the biopsychosocial post-injury response. And so essentially, every athlete is different. And we know this because we take care of athletes. And you have some athletes that have a lot of resilience and bounce back very quickly, and some that an injury can be devastating. And some of that is how we manage it. And that's where I come back to, if I take everything away, I take them out of their team environment, I take them away out of school, I take away their phone, I take all of this stuff, then mentally that can be really devastating. So we want to make sure we're not adding to the actual injury in terms of our treatment, causing more problems in the way that we're managing them. But all of these things impact each other. And so when we look at this, there's the cognitive aspects, which is you look at the sense of themselves, their identity, their loss. How much is this? If I identify as I am a soccer player, I am a softball player, and right now I'm not able to do my sport, then who am I? And so the athletes that really, that is their entire identity is as the particular athlete, sometimes they take it much harder than those who may be well-rounded, who I am a student who also is involved in my church, and I'm involved in something else going on, and I've got this sport that's a big part of my life, but it's not my entire life. They tend to bounce back a little bit better sometimes. How optimistic are they? And then you have the affect side of things. So is there depression? Is there anger? Is there anxiety? Are there fatigue issues? Are there other things that are going on that are contributing there? Maybe they had these issues coming into the injury. Maybe the injury has exacerbated some of these issues. They may or may not have had a diagnosis of these things. So it's not uncommon for us for a concussion to help bring these things to the surface. The way I think about it sometimes is like swimming. Some of these athletes have been treading water, just barely keeping their mouth above the water for years, between their schoolwork and everything that they're juggling. They're just pushing themselves to the limit, and they're just barely getting there. And then when they have the injury, they sink to the bottom of the pool. And because the injury has now taken away their ability to tread water in through there. And so they may have already been struggling. Maybe there was some anxiety there, maybe there was some depression there, but they were coping and getting along okay. Now we've taken away their ability to cope with that. And so that's something we have to kind of think about. Kinesiophobia is sort of fear of movement. So, somebody's got an ankle injury or knee injury and they don't want to move it because it hurts. Well, then if we don't move it, then we can't rehab it, and then they don't get better, and then they get stiff, and it starts that pain cycle. It hurts to move it, so I don't move it, and the more I don't move it, the more it hurts, and then I kind of spiral downward. What about their behavior? Are they doing what we're asking them to do? Do they want to go back to sport? Or are they maybe, so in our situation, a lot of times if you're in a school setting, has anybody ever had an athlete that they have held out of school because they've got a concussion, but yet they're still playing on their club sport? Show of hands. Anybody's ever had that happen, right? It's frustrating. They know, the coaches know, the parents know, and there's a reason we have them out medically, but they're out there playing. And so maybe they're trying to return to sport and now they're not getting better. We're trying to figure out, well, why are they not getting better? What's going on? Why are the symptoms not improving? Well, they find out they played 7 games over the weekend in a basketball tournament, or whatever it may be. And so that's a challenge. What does the social support network look like? It's definitely a team approach here. We kind of look at, you have to have the parental support, the team support, the coach support, the athletic trainer, school nurse, teachers, the physician, the administrators. Everybody kind of has to be part of this. And if one of those pieces is missing and is not on board and we're not all working together, that wheel is not round, we're not rolling well. And so there's a bump. And sometimes it may be the Spanish teacher. The Spanish teacher doesn't get it and doesn't believe in concussions and just makes them do everything. And it's like, why are they not getting better? So you have to kind of identify that. But they have to have a good support network. So all of those things can impact return to play. When we talk about, concussion's important, but mental health is also important. When we look at kids, this is ages 10 to 24, and this is, you look at the kind of causes of death, and unintentional injuries like car accidents, things like that is number 1. But number 2 is suicide. Number 3 is homicide. So these are very significant numbers here of what's causing this. When we look at suicide rates, now this is pre-pandemic levels, okay? Pre-pandemic levels, we're seeing the rates of suicide increasing exponentially. And then with the pandemic, it continued on that curve even more. And so we have a mental health crisis in the community, in the country right now. This is very significant, and it's something to think about. This is a big factor we need to manage, not just when an athlete has a concussion, but when an athlete has any injury, the risk is going to go up. And so I think that we all need to be aware of this. And sometimes, again, our treatment in an effort to protect the athlete may actually exacerbate these other things and may worsen them. So for example, if I have a patient who comes in who maybe has had multiple injuries and we're talking about whether or not to retire them from, let's say it's football, right? And maybe they've had a lot of injuries. Well, there's the medical side, but there's all of these other factors that go into it too. And so if I take away, we talked about identity. Maybe that athlete is their entire life, right now, and it is football or whatever their sport may be. And that's all they want to do, and that's all that they believe in. That's everything to them. And maybe there's already some depression in through there. And now if we take that away medically, even if we think that's the best thing medically to do, now what are the repercussions of that? What are the mental health aspects of that? So that's something I think we have to factor in that sometimes we don't necessarily consider, but that we definitely do. But especially for those who are out managing these athletes on a day-to-day basis, really keeping an eye on them, because it's very easy for them, again, if they've been swimming, they've been barely keeping their head above water, for them to sink very quickly after an injury, even if it's the first week or two, but especially if it starts to go on longer than that. Now they're missing more of their games, missing more time, they're away from their teammates. That stress really starts to add up, and so we really just want to pay attention to that. So coming back to this, again, after an injury, what are some of the differences? Maybe they don't have good coping skills, and some of that's innate, and we can teach them. We can give them coping skills. So if you're noticing an athlete that's struggling, there's things you can teach them. We've got a sports psychology team here. We often will work with them. They're having more emotional distress, like we talked about. They may not have a good social support network. Again, now they're not feeling like an athlete anymore because they're not able to participate in through there. And they may have not had a good psychological readiness at that point to go back. They're fearful of getting hurt again. I had an athlete this past week that he's going to be a senior, a football player, and he had a pretty significant concussion playing 7-on-7, and he's just not sure he wants to step foot back on a football field again for his senior year. And he's also plays baseball and does other things. And so trying to kind of determine what is normal fear, what is fear of injury, kind of as you work through that with them. and making sure you help regain confidence. But on the other hand, if they're not psychologically ready, if I clear that athlete to go put on pads and get on the football field and he doesn't want to be out there, now his risk of injury is significantly higher than it would have been. So you want to make sure we're addressing that psychological readiness as well. So when we look at prolonged recovery, I think most athletes will recover within 3 to 4 weeks. So longer than 4 weeks is where we start to say that's kind of what we call, now it's PPCS, which is persistent post-concussive symptoms. It used to be called post-concussion syndrome or other things along those lines, but persistent recovery. So taking a little bit longer to recover and through there. But that means that most of our athletes should bounce back within a month. If they've had a previous history of a concussion, again, any sort of neurological or psychiatric disorder. So this is one of the things that we ask about is either a personal or family history of anxiety, depression, bipolar, those types of things. Because again, even if the athlete hasn't been diagnosed yet, maybe there's a strong family history of anxiety and parents and siblings, and they've never been diagnosed. They probably had anxiety, it just hadn't been diagnosed. Now it's going to come to the surface. If we know about that early on, we can intervene as part of their management, maybe keep them from falling into that category. So we ask about that at their initial evaluation. Any learning difficulties, again, if they're already struggling, maybe they've got a 504 plan, but they don't use a lot of the accommodations, they're concussed and they're still struggling, that's going to compound that. Older children and adolescents tend to take a little bit longer to recover than some of the younger kids or adults. Lower SES, females take longer to recover, and then if they come in and they're more symptomatic, they tend to take longer to recover. That doesn't necessarily mean it's a worse injury. I may have a headache that I'm rating a 9 out of 10, and you may have the same headache and you call it a 3 out of 10, and we're just different. There's differences in our individual factors here, that our pain tolerance, our ability to cope, our resilience, all these other things that factor in. It could be that it's a worse injury too, but if they come in, they've got lots of symptoms, they're likely to take longer to recover. And so that's one of the reasons why I like getting that symptom scale early on and having them break through. Not only do you have these symptoms, but how bad are they? Because if they've got a 1 out of 6 headache versus a 6 out of 6 headache, then that's going to be a little bit different. So if they come in and they say, I've got a mild headache, mild nausea, and mild difficulty sleeping, I've only got a total of 3, that's not that bad. You're probably going to bounce back pretty quickly, hopefully, if you're being truthful, versus if they come in and they put 6 out of 6 on all 22 of my symptoms, there's probably going to be a long one. This is something I'm dealing with. I'm probably going to need to get that one in multidisciplinary care earlier on, intervene sooner rather than waiting for them to not recover, so I can kind of predict that they're going to take longer. Moving on to long-term effects. Again, this is these next couple of slides are from the newest consensus statement that came out. I will tell you, with the media, we all see, anytime that there's a new study that kind of comes out, the media jumps on it, and there's a lot of discussion about, this is caused by this, and CTE is something that we're seeing. And so now, I'm getting phone calls from adults, even though I don't treat a lot of adults, I'm getting phone calls from adults that say, Dr. Miller, I had concussions when I was in high school, now I'm 35, and I've got all these symptoms, I'm convinced I have CTE, but they've never been evaluated. There may be so many other things that can cause that. Maybe they have depression, maybe there's something else going on, there's other neurocognitive things, maybe there's substance abuse issues, maybe there's other things going on, dementia, so that they need to be evaluated, but not everything is CTE. But I will tell you, at this consensus statement, this is probably the most controversial topic that came up, and part of it is because there's not a lot of good data yet to really know. And so probably the next one, the 7th consensus statement, will probably have more direction on this. This is just sort of their review, basically saying that from the studies that have been done, we're not really seeing that athletes that have had a lot of trauma are having increased risk of psychiatric issues down the road or suicide related to that compared to people who are not involved. So they're saying the studies we're seeing there may not really match. Now that's in terms of psychiatric issues and suicide, but in terms of cognitive issues, there's been kind of mixed results. Some have said maybe there's some cognitive decline in those that have played longer years, more years of contact sports versus those that didn't. And then some that say, no, we really didn't find much difference there. And actually, we compared football players to marching band people in high school, and the people that played high school football are similar to the marching band people. And so there's kind of some mixed results in through there. But the concept is, so the CTE, the newer kind of terminology is CTE-NC. And the thing is that there's sort of the clinical presentation, meaning what we see in people, and then there's the pathology, meaning what we see on a slide of somebody's brain tissue on a microscope when they're dead. And so those are not the same thing, and we don't know if there's cause and effect or relationship in through there, but we're sort of talking about them a little bit differently. So the CTE NC is what we're seeing on a slide on the pathology. And so they said it's reasonable to consider that extensive exposure to repetitive head impacts, such as that experienced by athletes, may be associated with development of the neuropathology described as CTE NC, meaning saying, if somebody plays a sport and hits their head multiple times over the course of a long time, there may be some association that when we look at their brain on the slide years later, we can see these changes, this tau deposition, the amyloid precursors, and some of the changes there that look almost like dementia, but maybe, sorry guys, there may be a causal effect to that. But again, it's not a clinical diagnosis. You can't diagnose somebody who walks into your office who complaining all these symptoms with CTE. That's what we're seeing on the slide. But sometimes they're calling it traumatic encephalopathy syndrome, TES. Maybe a separate sort of clinical feature, but we don't know if those are the same and they're causative and through there. We don't know if CTE-NC causes neurological or psychiatric problems. We don't know if that can be clearly identified within the presence of Alzheimer's, or whether it's for sure going to progress on. And so we're sort of saying there may be an association. We don't really know. There's a lot we don't know, and we need to do more studies on that. And again, like I said, this was a pretty controversial one, so they weren't able to meet consensus on this, but there's a lot of really smart people on both sides of this kind of discussion, and so that's more to come on that. More research. So this was an interesting article. I thought it was interesting that they looked at the top 100 most kind of cited concussion articles over the past ever, and the top, at least at that point, the 4 consensus statements were in there. The other ones that we talked about, the American Academy of Pediatrics, American Academy of Neurology, the American Medical Society of Sports Medicine. So the top, 7 of the top 10 were basically some of the guidelines. So a lot of us, refer to these kind of guidelines. So that's, I think, of interest there. Some of the newer data that has come out in driving. We talked a little bit about driving earlier. This is some recommendations that we should be providing driving recommendations, but it's really unclear, and there's a lack of data on when can they drive, and what about if we just let them drive to and from school when it's daylight and it's not raining? Is that better than if they're driving on the highway at night with friends in the car? Or are there variations, and how do we measure that, right? We're making determinations on when they can go back to school, we're making determinations on when they can go back to sport, but how do we know when it's okay for them to go back to drive? And we talked about a lot of them are keep driving, even though they're not ready to go back to their sport yet. There was some studies where they put them in a driving simulator, even though they were clinically recovered from their concussion, and found that they had slower reaction time, and there may be some lingering impairment. And I think this is some overlap. There's this concept of neuromuscular control, and we're going to talk a little bit about musculoskeletal injury risk, but there may be, despite the fact that we think that they're recovered from their concussion and their symptoms are better and they're ready to go back, maybe they're not ready to go back to things just yet, so we may not have figured everything out yet. With vision, vision is a very common area that's impaired after a concussion. And this is not just in terms of driving, but in terms of all these. About 40% will have some vision issues. And so sometimes there'll be some reading issues with that, so they may not notice it until they go back to school specifically, or they're looking down to take notes and they're looking up at the smart board and they're trying to go back and forth. That motor function is impaired there, or trying to read across lines. They'll see things they're a little bit struggling there. And so a lot of times we will we'll screen for vision problems. The SCOTE 6 has sort of a brief vision screen as an optional component of that. I think that we do it fairly routinely as part of our exam here, looking at what we call the VOMs, which is looking at eye movements. We're looking at saccadic movements. We're looking at gaze stabilization. And so some of it, if, for example, they can't follow my finger, in the room, or look from one finger to the next very smoothly. If they can't go from this finger to this finger, and they're having a hard time catching that, then it's going to be very hard for them to read, because that's how we read, right? From one word to the next on a line, and we have to be able to shoot quickly and smoothly and then go down to the next line. So if our eyes can't kind of do that, they're going to struggle. So maybe that athlete, we can put in some accommodations to go back to school and say, go back and listen. Your brain is working well. You're going to do better listening and learning, but you're going to have a hard time reading. It's going to make you feel worse. You're not going to do it as well, and you're going to have to come home halfway through the day. We can keep you there if we have you doing more listening while we rehabilitate this vision. If they're having problems with gaze stabilization, which is where I'm focusing on a fixed object while my head is moving up, vertically or horizontally around, looking at a fixed object, that is makes a lot of sense. When I'm walking, I need to be able to look at the floor, not have the floor moving around. If I'm trying to play soccer, if the ball is moving and I can't focus on that ball while the ball is actually moving, my head is moving, my body is moving, I'm probably not going to do well with return to sport either. So that's, again, something else that we can look at. I also notice, for example, if they have a hard time doing this, the vertical gaze stabilization, again, they're going to have a harder time on the treadmill or running. Their headaches are going to get worse. So that one's one I'm like, hey, you're probably going to do a little bit better on the bike than you would on the treadmill. So I think it makes sense to look at some of the vision aspects of that. When I was a medical student, I remember, this was long before VOMs had come out, and this was back, I'm going to date myself a little bit, but we used to return athletes the same day, same game to the high school games. And that was standard of care at the time. We graded them and looked at them and we put them back out there. But I remember one of the athletic trainers at the time, the kid came over and he said, okay, look at my face and shake your head back and forth like this real bad and see how you feel. And the player, kind of looks at him and goes, oh, he goes, oh, you're out, And I didn't realize it, but he was doing some gaze stabilization, right? And so making sure, he's like, look, if you can't do this, you're certainly not ready to be on the football game. And I think he had already made his decision, but he was convincing the football player that he was done and he wasn't going to put him back in. But we would commonly put him back in. So I'm glad that the kid kind of did this, because if not, I don't know, we maybe would have just let him go back. But we've changed a lot through there. So we mentioned medicines. There's not a lot of great data showing different medicines. Sleep is often an issue, and melatonin has been used. This was several studies that looked at melatonin. Melatonin, I think, is fairly safe in the short-term setting, so I do use it some, but they didn't really find much of an effect on getting patients feeling better. But when they looked at those who were taking longer to recover and having sleep problems, it did help. So maybe selectively using it in those that are having a hard time, but not just across the board on everybody in through there. So some melatonin may be helpful in those that take a little longer. Concussion risk. Those that have had a previous history of a concussion have a 4 times greater risk of concussion, of having another concussion. Now, is that because if you got hurt playing soccer, which is a high-risk sport, and you're going to go back to playing soccer, your risk is higher? Or is that because you've now had the injury and now your brain is more susceptible? Or is that because you were doing some different playing style? Maybe you led with your head, you're more aggressive than somebody else that's out there. Or maybe it's a combination of all those. So I don't know that we can say for sure that the concussion itself now has made you more susceptible to having a future concussion, but there may be some thought to that, and that's probably part of the reason why when we start to see multiple concussions, again, whatever it is, there's a trend here that you're getting concussed a lot. It's probably not an ideal thing for you to continue to play that particular sport, especially if you've had, sometimes we'll have kids that come in, age 10 or 11, we're already seeing them for their 3rd or 4th concussion. That's worrisome when they haven't even been to middle school or high school sports yet. It's likely that they're gonna have a lot of injuries if they pick a contact sport moving through to middle school and high school. So maybe that would be one where we might sort of say, hey, let's counsel you to move maybe a different direction so you can still be just as successful in a sport that has a lower risk of concussion. For prolonged recovery, again, we talked a little bit about this, but I think hitting home on that psychiatric and neurologic, background, really looking at that with them. Parasports. We have a lot of interest here with adapted and parasports. These are athletes of all different abilities, but and we have at UT Southwestern the Adaptive Sports Coalition. So there's a lot of great opportunities out there. I don't know, just show of hands, how many work with adapted or adaptive athletes? Either Good, so a few of you do. And I think that's one of those things that we want to encourage participation among everybody, right? We want all groups to be participating in sports, but there's really just not a lot of good data when it comes to managing concussions, especially in the para or adapted athlete. And so this was a consensus statement that came out in the concussion and parasport group, which is great. So a lot of people similar to what they did with the sixth consensus statement. But they basically said there's unfortunately not a lot of data out there. Baseline testing is probably even more important in this population because trying to guess what's a normal baseline for them is really challenging. And a lot of athletes, if you think about, depending on what you're doing, it's pretty easy to get a concussion. And so I think we had... we do, for example, every year an annual ski trip to Colorado where we take a lot of our patients, our amputee patients. And so you can imagine if you don't have arms and hands to protect yourself as you start to fall down a slope, maybe you're more likely to get a concussion. So same thing if you're in a wheelchair, you're playing wheelchair basketball or rugby. If your chair goes over, you may not be able to get your arms up in time to protect yourself and you may hit your head. So we really, it's a very active population and we want to make sure that we're treating them well and looking into some of these things. This was interesting, I thought. Those who are hard of hearing, hearing impaired, had a higher concussion rate than those who are not. So, So it may be greater in athletes who can hear versus those who are deaf or hard of hearing. They did a study there, so I thought that was just of interest. This one is a big one that I think we're going to see more and more data coming out. We are seeing that after a concussion, there's a higher risk of musculoskeletal injury. And so that comes back to that concept of what is going on. Is there still some neuromuscular deficits? When we look at, for example, somebody who's had an ACL surgery, when they're rehabbing them back, the graft may be strong, they may be strong in their muscles, but if they don't have the neuromuscular control to protect their knee, they may be at increased risk of tearing their graft or tearing their ACL again. So same thing when somebody's coming back from a concussion, the brain is so incredibly complex. If they're just off a little bit here, they're not able to control themselves here, they're more likely to sprain their ankle or perhaps twist their knee and get an ACL injury. And so it's significantly higher. So it was about 1.7 times higher there. To have an injury, and then 2 times higher in some of these other studies as well. So this is something that I think, like I said, we're probably going to continue to incorporate more dual task and multitask type assessments into our return to sport decision making. That's where the assessment of them on the field is also really important, and reintegrating them back into things and seeing how they move. We're doing a lot of studies here. This one is a UT Southwestern-led study. It's called Context. I'll talk about Context too in a second, but Context is just a registry where basically any athlete that comes in with a concussion, or anybody with a concussion actually, that comes into our clinic or comes in at Children's or comes in at UT Southwestern, we're trying to enroll them into this database so we can follow them and see how they recover and see how they do and study them. We've done a lot of studies with that. We've got SCOPE, which is sort of a national group. We're part of a group of pediatric sports medicine hospitals and facilities across the country where we're looking at that. Our movement science lab here, and I'll show you some scenes from that shortly, but we have a really cool sort of biomechanics lab here, and we're doing a study looking at, right now, for example, what we're doing is we're having the athletes, when we clear them to go back, and they're about to start their return to sport progression, we'll have them come in, we'll do some gait assessments with them, and then we'll put them on the bike and fatigue them on using the bike protocol, and then we'll test them again and see how that exercise is impacting their ability to perform. Because again, if you're putting them out at practice and they go out and exercise, is there neuromuscular control? Are there going to be changes in there as they start to fatigue? DHA, we did a study looking at fish oils or omega-3 fatty acids, and found that the athletes that we had take DHA at the time of the injury got back 5 days faster than those who didn't. So it's one of those things I typically say can't hurt, might help. I can't tell you that there's a lot of studies that have been done. We're the only one that's been done in humans as a treatment into there, so we'd like to expand that and do that on a bigger scale and see if that effect actually plays out. But again, if you have an athlete and you can get them back a few days sooner, then that's probably something reasonable to think about. Return to play, we'll talk about here in a minute as well. Context 2, how many of you are currently enrolling athletes into the Context 2 database?
that you know of. So, okay. So Context 2 is through the UIL and came through from the Medical Advisory Committee. It's sort of a prospective study through UT Southwestern and the UIL. Right now, it's implemented in all 6A schools. So all 6A schools were required to report this. I believe it's through your Rank 1 sports. So if you're entering the data into Rank 1, then you are participating in Context 2 because that's being pulled there. And they're going to expand it out to the rest of the schools, but COVID has kind of delayed things. So when we look at some of the data that's come out of this here in our state by grade level, if you look at concussions overall, middle school ones are not really being reported much because I think a lot of that's the high school ATs that are putting these in are mostly at the high school level. But freshmen, especially at the freshman level, we're seeing more boys than girls, and that may be that there's a lot of freshman football players that get concussions. And then in sort of equivalent, slight male predominance in sophomores, juniors, and seniors, decreasing numbers, but that may be a decreasing participation. As we get older, there's less seniors playing than there are maybe freshmen and through there. When we look at which sports injuries were being reported in the girls, again, soccer was number 1, basketball number 2, volleyball, softball, cheer, and wrestling. And then in boys, of course, football is about 2/3 of all the injuries, with soccer and basketball being number 2 and number 3 in there as well. So probably consistent with what you guys see. The events, about 50-50 in terms of happening at practice, or 39% practice and 39% during a game in terms of where these injuries are occurring. Some of them are happening not playing sports, whether that's off campus or car accident or hitting their head on the locker, that kind of thing. And then about 7% were happening at a sport outside of school, then coming back and seeing the athletic trainer. Most of the time, these were being reported within, most of them were at day 0, the day of the injury, and then day 1. And then after that, they kind of slowly get reported. But the average time to evaluation was a day and a half, which is great. That tells us what we think, right? The athletic trainers are very well positioned to help intervene early and educate the athlete and start all of these things that we've been talking about early on, whether it's school, physical activity, all of these things, they're keeping them out of their sport, because I can assure you that's much less than them getting in to see, the doctor most of the time, or certainly getting in to see a concussion specialist. So talking about, I said I was going to talk about return to play. This is kind of a sad but real story that happens. So this was a girl who this is a real text exchange with her friend, and so she's the white. She says, I might have gotten a concussion. I have a headache again. Her friend says, well, how'd the game go? I smashed my head on the ground, and then I got kicked in the head. And she said, doesn't that happen every time? I mean, it's rugby. Yeah, which is why I probably have a concussion. Well, you need to stop doing that. Her friend says, are you still going to play on Wednesdays? Yeah. Nothing can stop me unless I'm dead. Her friend says, well, I'm sure you'll be fine then. She's like, unless I have a concussion. She says, are you going to go get it checked out? Nah, I'll just see if it gets worse. You should go see a doctor. What's some brain damage going to hurt? So is this something that we deal with a lot? I think, yes, we deal with this quite a bit. And then if we have somebody telling us that, so I think this is where the teammates are really important, right? That friend can kind of help advocate. And we have seen this some increase. I would say it happens more than I would have thought at the football games. We'll have athletes come over and say, hey, AT coach, doc, so-and-so is not right. They need to be checked. And so that's in the game, and that's awesome. But it also afterwards, right? If they're reporting, and sometimes we'll have our student athletic trainers come in and say, hey, look, so-and-so is complaining of headaches and telling everybody he's got a headache and he's taken Advil, but he hasn't told you guys. And so that's really courageous and important. We need to empower all of them to do that. And is she at risk of other injury? So she got hurt on May 3rd, and then again 3 days later when she got kicked in the head, that was that one. Texted her symptoms, and then she kept playing, and then on May 8th, sustained a fatal brain injury. Nobody diagnosed her with a concussion. No adults were aware of her concussion. She was hiding it, right? And this is where I come back to saying we can't expect coaches to know. Even we who are covering the game may see this, and these can be silent injuries, and they can be suffering in silence and not telling us. She felt responsible. She kept wanting to play. She had been Googling concussion. She already knew she had a concussion, but she chose to withhold that information because she didn't want to come out of the game. And so we've found here that the patients that we see with a concussion, more than half of them report that they've kept playing. We'd like that to be zero, right? I mean, as close to zero as possible. And so that's a really big number. And that's still now, despite all the awareness and education, they're still saying that they're injured and keep playing through it. So why? Well, sometimes they felt okay. The symptoms haven't evolved. Sometimes they wanted to tough it out. Some of them don't know it's a concussion, felt pressured, or a small percentage, 2%, got cleared by their AT to kind of keep going back. So we don't want to be in that 2% for sure. Just to talk about some of the technology, it's been around a long time. If we just keep adding helmets, this is the new version, right? That's the old version. This is the new version. That's the Gary Busey version, the helmet protector. And so, at some point we kind of have to look at maybe some differences in rules and such. Guardian caps have been added to the NFL. You saw Natasha Helmick wearing the full 90 headgear. I think that I like that people are trying, but we don't have a lot of data yet on some of this equipment. This is the Movement Science Lab, showing some of our athletes doing different testing, and through there we put markers on them and can really do great assessments there. Then we can kind of make a video game type model of them and make accurate measurements. So this is sort of what that looks like. And through there, if they run and jump. So this is some of the things. So if you have athletes that are doing this, we're doing studies both on uninjured athletes as well as injured athletes. Right now, specifically, we're looking for distance runners. So if you have track athletes, cross-country athletes, please send them our way. We're having them run. If they don't have to run the full 5 miles, but we're having them run 5 miles, and we're looking at their gait mechanics and seeing as they fatigue. We're bringing them through. We've got a track, and they run around outside and stuff. And they can bring in, their team, come in with teammates, make it fun. So we're trying to do that. So talk to me if you have cross-country athletes that you'd like to give about. So we have made it through 2 hours of concussion, and I'm still talking, so I'll stop. But let's see, time-wise, where are we? Okay, so when are we supposed to? Okay, perfect. So we have about 5 minutes for some Q&A, and then we'll break and let you guys get off to the breakout session. So what questions do you guys, Mary? Yeah.
I think my coach already purchased them. Sorry. Mary, Leaf Blood, athletic trainer, Q collar. What have you seen? I mean, right now we're seeing positive results with that. So those of you who don't know what that is, it's this little thing that athletes can put around their neck, and it's supposed to restrict the blood flow to the brain. So if they do sustain a head injury, that the blood flow is supposed to help the metabolic.
So it's a jugular compression device, and so the theory behind this is they looked at woodpeckers, for example, and when woodpeckers bang their head all day on a tree, they don't get a concussion. So what's different about woodpeckers? Or mountain goats that ram their heads and they don't get a concussion. And so they find that there's a little bit less what they call slosh, meaning the brain doesn't slosh around quite as much in the skull and through there. So perhaps if there's less slosh, maybe it's a lower risk of concussion. So the thought is if I wear a really tight necktie or I wear this jugular compression device, well, blood can go in, but it can't come out as easily because the veins are sort of cut off. So maybe in theory there's less slosh inside my head, which would increase, or in theory decrease the risk of concussion. So the studies that I've seen have only looked at some of the MRIs and functional and finding some changes in through there in terms of white matter and things along those lines. I have not seen any studies yet that have shown a reduction in the risk of concussion, either individually or over a team or the course of a season through there. There is some concern among the neurology community, among the physicians, about the risk of us artificially increasing the pressure inside of our brain for a prolonged period of time, that's not a natural thing, and it may change some of the receptors and such and through there. So it's interesting because, and I know, so Greg Myers, one of the scientists who's done a lot of research on this, and I've had a chance to visit with him a lot. He's very excited about it, and there may be something to it, but I also hear the other side a lot of the physicians are saying this is not ready for prime time yet. We need to study this to find out what the significant effects may be, and so to be determined. But yes, I've gotten that question actually 3 times in the past month from other physicians and such, too, so it's definitely out there.
My coach is thinking of using these for our high risk, our kids who have had them in the past, given the, like.
Yeah, I don't know that I can recommend it yet. Yeah, it may work, but I hesitate a little bit with it.
Hi, Dr. Miller. This is Lex.
Hey.
I have a question about the acetaminophen. I typically tell my parents that you can go ahead and take 1 dose just for the initial headache, but I've been having issues with an athlete who takes it over and over, and as we're doing our return to play or they're checking in and they're rating their concussion as 0, but they're still taking acetaminophen to, get rid of those symptoms. So what is your opinion on like how we can regulate that a little better?
It's a great point. So I think one of the points of clarification would be is when we're talking about them being symptom-free, they need to be symptom-free off of medications, to me. And so if I've started them on a medication for focus issues, or if I've started them on a medication for headaches, then they need to be off of that unless we think they've developed a headache disorder and the concussion is resolved. Sometimes we'll put them back if we're treating now migraines or something different. But yes, if they're having to cover up their headache with Tylenol on a daily basis. Now, you can get what are called medication overuse headaches, which is after a week or longer of taking, whether it's Advil or Tylenol or whatever it may be, consistently for a headache, it's almost like you become addicted. And so once the medicine wears off, the headache comes back. And so then we have to just stop the medication. And so sometimes it's trying to figure out what is still the injury, what is now a headache disorder, and what is now a medication overuse headache that's just being caused by them continuing to take medications. So I agree with you. It's not something I like them to be on long term, but in the acute setting, I don't have any problem with them doing it, to help them get through the school day, things like that. But yes, before they're back to playing their sport, we don't want them on that. But, a significant number of teenagers do have headache issues. And so if, for example, they had headaches prior to their injury and now they're back to their normal headaches and they would normally take a Tylenol or Advil for their headaches, and then they're trying to clarify, is this your normal headache? Is this concussion? Working through that with them. But if it's a new problem and they're taking it consistently, I would tell them that doesn't count.
Great. Got one more question here in the back.
Hello. My name is Megan. I'm one of the athletic trainers here. Dr. Miller, I want to know your stance on some of these devices athletes can buy to help prevent concussions, especially if you're prone to them, like the headbands or the mouth guards. How do you feel about those?
Yeah, that's a great question. So asking about other sort of preventive things. I am a big fan of mouth guards. I think mouth guards, there's some data in especially protecting obviously the teeth and the gums. And so I think in contact sports that you absolutely should wear a mouth guard. There are definitely a lot of benefits to wearing a mouth guard. Could it reduce the risk of concussion? Possibly. I don't think there's any drawbacks to wearing a mouth guard, so I definitely like those. With the headgear, there's been some pretty good studies. Unlike the Q collar, the headgear, they've done some good studies comparing where they put some teams in headgear for the season and some teams didn't get the headgear, and they followed them over the course of the seasons, and they haven't found that there's any difference in reducing the risk of concussion. So same, the soccer ones. Yeah, so looking at the soccer, the headgear. So the kind of the protective padding that basically goes around and through there. And so, it may reduce the risk of getting a cut or things like that, but we haven't been shown. There's some concern that putting an athlete in something like that makes them feel safer, and so they may lead with their head and may go for a header or do something different than they might not have. But I'm not significantly opposed to the headgear. There's just no data to show that it makes a difference yet, but I am in favor of mouth guards.